You're in the vibrant diamond city of Surat. I hope you all had an enriching and enjoyable day one, from the scientific sessions to the lively discussion, and of course, the wonderful networking. After a power-packed first day, I trust you are refreshed, re-energized and ready to dive into another exciting day of learning.
Today's sessions promise an even deeper exploration into the challenges and innovations that continue to reshape critical care medicine. With an exceptional lineup of speakers and thought-provoking topics, we are all set for a day that will stimulate our minds and sharpen our clinical practice. Thank you for being here with such enthusiasm. Let's begin day 2 with the same curiosity, collaboration and spirit of learning that defines this conference.
So we are starting with the first scientific session. I would like to invite Dr. Sameer Trivedi sir and Dr. Kalpesh Joshi sir to head this session.
Glucocorticoids are an important member of ICU squad. Indications are specific and not broad. When used right away, decision is always adored.
And to understand this topic better, I would like to call upon stage Dr. Chinmay Pathak.
Good morning, friends. It's my intense pleasure to introduce Dr. Chinmay Pathak, a consultant intensivist at Bailal Amin General Hospital, Baroda, with special interest in sepsis, mechanical ventilation, and focus in intensive care, extracorporeal therapies, and palliative care. Without taking much time, I request Dr. Chinmay Bhai to start his lecture. Thank you very much.
Let us start our first topic of the day without wasting much of time. Corticosteroids we are using day in, day out. Very much familiar kind of molecule to us. So I don't think there should be much of a discussion. But most important thing I have to point out is that the most commonly used indications in the ICUs are the most controversial ones, and less commonly used indications for the steroids are kind of quite much with the evidence supporting the indications. So let us just start with the basic thing. Next slide. So before we move on to the indications, it is really necessary that the molecules which are the agents which we are using, hydrocortisone, dexamethasone, methylprednisolone and so on. So it is really important to know that, so it is really important the agents which we are using, the glucocorticoids which we are using, they have both the glucocorticoids and mineralocorticoids activity. So here you can say the hydrocortisone, most commonly used agent, it has a 50-50% of both the mineralocorticoid as well as glucocorticoid activity. It is 1:1, right? And methylprednisolone, here you can see this is, it is most potent glucocorticoid and very less amount of mineralocorticoid potency. Another most commonly used dexamethasone agent, it has total 100%, near to 100% glucocorticoid potency, which is most potent glucocorticoid and almost zero mineralocorticoid property. Let me just tell you that which is the glucocorticoid properties and which are the mineralocorticoid potency. So glucocorticoids basically we are using in our ICUs basically to have anti-inflammatory effects of the steroids, immunomodulatory effects, and it has, glucocorticoids also has some effects on the protein, lipid, metabolism also. Whereas mineralocorticoid receptor, mineralocorticoid basically controls your minerals and electrolytes, water balance into the body, right? So it affects on that also. So we have to be very much clear into our minds that for which indication you are using and for which indications you don't want mineralocorticoid effects in your patient. And that is how you choose the steroids in different conditions. Let us just talk about the common uses. I'll just touch upon the commonly used ICU indications, commonly used ICU situations in which steroids are being used. There is a long list of indications of steroid which I think even 1 hour or 2 hours lecture will also be not enough. So I'll try to cover it within 10 minutes. Most common, septic shock, ARDS, acute respiratory distress syndrome, airway edema on tracheal extubation to prevent stridor and reintubations, hypoxemic as well as hypercapnic respiratory failures, status asthmaticus as well, And severe community-acquired pneumonia, mind well, we are not using it into the less severe pneumonias. Critical illness-related corticosteroid insufficiency, spinal cord injuries, dengue, most commonly used, but let us just talk about it, that whether we are treating our patient on evidence base or not. Anaphylaxis, raised ICP due to various reasons, for tumors, for metastasis, for meningitis, or for the hemorrhages. So these are the most common indications, and now little less common, polytrauma, burns, questionable role, adrenal crisis, hypothyroidism. I think most in our hospitals, this endocrinologist takes care of this, so we'll not touch upon this. Organ donation, before, to prepare the organ donor, there is very much use of the methylprednisolone. We use it routinely. Perioperative replacement if the patient is on a chronic use of steroids. PCP pneumonia, pulmonary fibrosis, meningitis, and immune modulation. There are a whole lot of range of rheumatological and autoimmune conditions, which I think it is beyond the scope of this talk, so we'll not talk about that. Let us just start with the septic shock. Most common indication is our ICU. We have a table of few landmark trials into the role of steroids into the septic shock, starting from 1988. Even before that, there were so many trials regarding use of steroids in the septic shock. But we'll touch upon the most common and the most relevant trials. So Annan and team in 2002 had a 300 patient in his trial, and which has used hydrocortisone 50 mg every 6 hourly plus fluorocortisone 50 mics daily. So it shows a positive outcome, improved 28-day mortality in patients without ACTH stimulation test. So to prove that patient is in SIRCI, which is corticosteroid inefficiency, you don't have to do now ACTH stimulation test, but this was the protocol which was used in this trial. Another trial was a corticos in 2008, which has around 500 patients in which hydrocortisone 50, same dose was used within 72 hours of septic shock. And it was a little, the primary outcome was not achieved, no difference in survival, but it improved the time to resolution of shock in those patients. Another very important and very landmark trial, adrenal trial, which the whole world in 2018 was awaiting, the results were awaiting for the adrenal trials. Around 3,600 patients were included in this trial, which used hydrocortisone 200 mg per day as an infusion for 7 days. And here also, to our surprise, that there was no difference in the mortality, but yes, it improved the time to shock resolution. Another trial in 2018, same Anand team approached this trial. Around 1,200 patients were there, in which they used hydrocortisone plus fluorocortisone therapy, same which was used in 2002. And it again showed improved 90-day mortality, 180-day mortality, and vasopressor free days and organ failure free days at day 28 also. There was little amount of hyperglycemia in patients in which both the steroids were used. So there was again concurrent review in 2015, around 33 RCTs, 4,000 patients were hospitalized patients with septic shock were randomized, and with low quality of evidence, they have shown that steroids reduce mortality among patients with septic shock. Not only sepsis, but septic shock. Long course of low-dose steroid reduced 28-day mortality without inducing major complication, which has a moderate quality of evidence. Again, in 2017, one meta-analysis, 22 studies and partial data on one study. No clear evidence that this corticosteroid drug, or for that matter, any regime, has more likely to be effective in reducing the mortality. But as a whole, hydrocortisone delivered as a bolus or infusion was more likely to resolve the shock. So, in and all, 2024 Society of Critical Care Medicine and ESICM guidelines have properly delivered the guidelines and properly guided us and recommended us how to use steroids in which condition and how. So, steroids should be used in septic shock, in non-septic patients. In septic shock patients, hydrocortisone 200 mg per day with or without fluorocortisone 50 mics for 7 days. So, if you are using steroid in septic shock to improve the mortality, then yes, we have to look upon these studies and we have to just focus on resolution of shock. So, no mortality benefit in septic shock. It only helps in shock reversal. It should not be used in sepsis without shock, right? So for septic shock, we are all clear. Let us move to another condition, ARDS. Again, so many trials, so many studies. I've included some landmark studies, Maduri 98. Very small study, but they have used methylprednisolone 2 mg per kg. It improved the lung injury severity score, and in fact, it improved the ICU and in-hospital mortality also, way back in 98. Then in 2006, Steinberg and team, ARDS net trial, 180 patients were with moderate to severe ARDS as per the guidelines were included, and they have used again 2 mg per kg of methylprednisolone for 14 days, and then it was tapered. But the results were mixed. There was no difference in mortality, but yes, in fact, in the patients in which the steroids were used, after 14 days, the mortality had increased. So certainly a takeaway point from this study. Maduri again, 2007, small study in which a lower dose was used, 1 mg per kg for up to 20 days, a little longer duration, which also showed improvement in the length of hospital stay, duration of mechanical ventilation, and ICU length of stay. Little bit positive study for us. Then again, landmark trial 2020, Villar and team, Dexar ARDS trial, in which they have used around 250 plus patients were there. Sample size was big enough. Dexamethasone 20 mg per 5 days, and then 10 mg per day for up to 20 days were given. It also showed improved ventilatory-free days at 28 days. Again, a very big meta-analysis of around 1,300 patients, Lean and team, has shown improved mortality, ventilator-free days at 28 days, and improvement into the PF ratios. We can just see the forest plot here. So we can have an idea that effect of glucocorticoid here, this is on the mortality in the RCTs. So you can see that certain trials here which are not crossing the lines, which are not crossing the midline, Maduri trial, this REG trial, and Maduri again, which is a little positive towards methylprednisolone. And if you see here, the agent dexamethasone, methylprednisolone, or hydrocortisone, so except for hydrocortisone, methylpred and dexamethasone has shown a beneficial effect in treating the ARDS patient. You cannot see here, I have just put this data. There is again a big recent meta-analysis in 23. Around 9 RCTs and 11 observational studies were studied. You cannot see from here, even I cannot, but I have put this because all the studies and all the trials have different regimens included in their trials. So either it be a methylprednisolone, dexamethasone, or hydrocortisone. So we'll just go on to the forest plot. What they are saying is that in RCTs, the benefits of steroids were clearly seen here. But if you see the observational studies here, the I square is 70%. If you see this, so it is a more heterogenic result. I square is 70%, which means the observational studies have clearly thrown out the steroids. So there was totally different perspective and totally different results were seen when it was the meta-analysis were done for observational studies. But taking into the whole as a whole, and you combine the data of both the RCTs and observational studies, then yes, steroids were beneficial. Now, which steroid? The question comes, which steroid? So here also you can see that dexamethasone, methylprednisolone, and hydrocortisone, different studies with different regimens have been used. And you can clearly see that the methylprednisolone and dexamethasone has definitely an edge over the hydrocortisone. In both the forest plot you can see, right? So what guidelines say? Again, the SCCM, Society of Critical Care Medicine, surviving sepsis guidelines as well, and European guidelines suggest use of steroids in patient with early, moderate to severe ARDS with PF ratio of less than 200 within 14 days of disease onset. That is the take-home message for you who are treating ARDS day in and day out. These are different regimes. If you are using within 24 hours, then yes, dexamethasone may help us. If you are using within 70 hours, then methylprednisolone 1 mg per kg bolus, and then tapering over 4-5 days. Again, if you are using a little late in ARDS, around 7 to 21 days, then you start it with the 2 mg per kg IV bolus, and then taper it every 7 days, 5 to 7 days. So, corticosteroids are harmful in late ARDS and not to be used. That is the dictum. And recent evidence signals towards possible benefit with the use of steroid in ARDS. So that is what we have to keep in our minds. Now, community acquired pneumonia. So only the severe caps are involved. Day in, day out, we are treating our patients with community-acquired pneumonia. Here are some trials which are showing beneficial effects of steroid only in severe community-acquired pneumonia. So many trials. Way back in 2005, a little less sample size trial, but they have used hydrocortisone 200 mg and then 10 mg per hour for 7 days, which showed improved mortality, hospital length of stay, and progression to even septic shock. That was little controversial. Again, if you see another studies, 11, 15, 20, 22, Madhuri and team, that is called ESCAPE trial. Around 550 patients in ICU and step down were included within 72 to 96 hours of admission. They have used methylprednisolone 40 mg daily, but it was a negative trial. But that was a primary outcome. Yes, if we consider the secondary outcomes, then mechanical ventilatory free days as well as hospital length of stay, ICU length of stay, they were all decreased. So it is really imperative for us to know that it is not always the mortality outcome we have to take into the consideration. Also, there are other parameters we have to see when you are using some agents like steroids. Dekin and team 23, cap code, very recent trial, very big trial. Around 800 patients were included in which they used the same dosing, hydrocortisone 200 mg daily for 4 to 7 days and then tapered off, which was significant kind of a trial which has shown and which has made the guidelines very clear. And now the 2024 Society of Critical Care Medicine guidelines have written very strong recommendation that you use steroids in severe cap based on this study, cap code trial, which was a landmark trial, which improved the 28-day mortality also. And it also achieved every other secondary outcomes. Just to let you know that what are the conditions or what are the signs, symptoms, and which patient you have to consider is having a severe cap. So different trials use different definitions. American Thoracic Society and IDSA has included these many trials. So ultimately, so many of Lendlease, when the patient lands them into the ICU and the pneumonia patient requires ICU care, that means he is going into the severe cap. Basically, cardiovascular, respiratory, any support of the patient is requiring, and other biochemical parameters like uremia, leukopenia, thrombocytopenia, then you are going into that. Again, cap code trial has also included same thing, so we'll not go into that. But yes, the guideline says, SCCM guidelines 2024 strongly recommended that you use only into the severe bacterial community acquired pneumonia, very strong recommendation. I will not go into the details of, I think very less time is there. So, but again, just to let you know that REMAP cap trial, which is a very big trial, different platforms were studied in which these guidelines have been challenged because the results of REMAP cap have shown quite a big trial in 101 sites across 18 countries, and the result is not it has not improved the 90-day mortality. The only positive thing was significantly lowered the duration of cardiovascular support inotropes in the hydrocortisone. So again, hydrocortisone has improved the shock reversal, nothing else. So the REMAP cap conclusion, very big trial, which has now challenged the 2024 SCC guidelines that it is unlikely to yield a large reduction in the mortality. Just a few slides, I'll take just 2 minutes. COVID-19 pneumonia, no need to discuss. Only one trial is enough, RECOVERY 21. Dexamethasone 6 mg have improved mortality. Again, the meta-analysis by the REACT working group has also shown the positive effects by using steroids. SIRCI, we all know, just to point out that what is SIRCI? SIRCI is basically critical illness-related corticosteroid insufficiency. It is to describe the impairment of HPA axis during critical illness. The term was coined in 2008 by SCCM and ESICM. So all the CAP, ARDS, sepsis, cardiac arrest, head injury, trauma, burns, post-major surgery, all are the causes which is kind of a stressful condition to the body and which impairs the HPA axis. Hypercapnic respiratory failure, again, pulmonologist review, but again, we routinely receive this kind of patient in our ICU. So yes, both in COPD and asthma, different dosings are useful in and which is supported by the guidelines also. Anaphylaxis, I'm not going into this trial, but just you see this table, it has used to prevent the biphasic response only, not useful to mitigate any immediate reaction. So we reflexly use steroids into the management of anaphylaxis, but mind well, it is not useful. It is only useful to mitigate the biphasic response. And if you are using, then it has to be only used for 48 hours, and then you have to stop. Now, pre-extubation to prevent stenoid, yes, most important thing in ICU, traumatic intubations, prolonged intubation, high-risk patients. So they have used dexamethasone 4 hours or methylprednisolone 4 hours prior to extubation, and certainly this high-risk group have definitely done well. So steroids only beneficial in high-risk patients for preventing stenoid and reducing reintubation rates. Benefits are seen when it is administered 4 hours prior to extubation, but routine use is not recommended. Right? Spinal cord injury, will not go into detail, but definitely it is controversial, and NASIX 3 studies have thrown out steroid from managing the spinal cord injury. I think you all must be aware about the initiation of methylprednisolone. When you receive a patient with spinal cord injury, 8 hours के अंदर methylprednisolone load करो, फिर चालू करो infusion. Everything is out now. Right? Polytrauma, no role. Burns, no role. Dengue fever, most important topic which we are using in our ICUs, absolutely no role in any stage of treating the dengue patient, even if it is DSS. It is only useful when you are treating HLH related to the dengue, then only you use steroid, otherwise no role of steroid. Right? Raised ICP, no role in hemorrhages, only role in meningitis and tumor and metastasis. That's it. So you are, someone said definitely that it is a double-edged sword, so we have to be aware of the side effects also, which we already know, so we will not go into the side effects details. So to conclude, it is definitely a controversial thing to use into the modern intensive care. The benefits and the risks we have to weigh, and then only we have to use the steroids in our practice. Thank you.
Thank you.
Thank you. Thank you, sir.